Let's look at the cell signaling to understand how several drugs that we have available work. So on the left, we have a generic cell, and on the surface, the cell could be expressing receptors either to soluble ligands like cytokines, or it could also be a receptor to homing receptors, cell adhesion molecules, or co-stimulatory factors that in this case are bound to a membrane of another cell. So either way, the purple cell with the green nucleus shown in here has these receptors on the surface. And what I'm focusing on the right is what happens to activate that cell. So whichever it is, the receptor that is engaged either by the soluble ligands or by a co-stimulatory factor, the engagement of the receptor on the cell will produce the activation. This activation is basically by kinase activity where there's phosphorylation, and these kinases will activate intracellular secondary messengers that could be in a relay or directly go to factors that actually translocate to the nucleus and activate gene transcription. So this is a generic way by which receptors usually work. So this activation is a chain of events that begins with the extracellular engagement of the receptor on the cell. Biosimilars and biologics will work on blocking that first interaction. These are large molecules. They do not penetrate the cell, but they could bind either the ligand. So it could be, if we think of a cytokine ligand like TNF, we can have an anti-TNF. So TNF is no longer free to bind the receptor, or sometimes they can actually bind the receptor on the cell. And by binding the receptor on the cell, even if the cytokine is free in soluble form, the receptor is not available, is occupied, and is blocked. So by either using a target that's soluble or a receptor that is specific for a particular cytokine or a growth factor, we have biologics or biosimilars that can block that interaction. The important thing is that by not having this interaction, then what happens is that there's no activation. And by not having activation, even when the cell is intact and it has the kinases and the receptor intact, there's no gene transcription because there's no activation. This is the way that most of the biologic and biosimilar drugs we have in the armamentarium of therapeutic drugs, this is the way they work. Examples are ample, and we can have, for instance, blockade of co-stimulatory factors and cell adhesion molecules. So, for instance, abatacept will actually bind, it's an antibody that binds the B7-1, B7-2, also known as CD80, CD86 on the T cells, and basically it prevents a co-stimulatory factor. The checkpoint inhibitors work actually on a similar pathway. In this case, they will be inhibiting an inhibitor factor. So they stimulate the cell by not having inhibition. They block those inhibitory pathways. Rituximab will bind the CD20 receptor on the B cells, and it actually will prevent the further maturation of B cells, and it actually will produce killing of the cells that express CD20. Likewise, Herceptin will bind the HER2 bearing cells. The HER2 receptor is basically expressed on breast cancer cells, and so what it does is by binding is internalized and it kills the cell. And TVU vidolizumab is going to inhibit a cell adhesion molecule that is expressed. It's a co-stimulatory factor, a homing receptor factor from the T cell that actually takes the T cell to the inflammatory bowel epithelium and allows the T cell to migrate, infiltrate the epithelium and causes inflammation. But by blocking it, the T cell is no longer able to go to the target organ. So they work in the same way. They're blocking co-stimulatory or cell adhesion factors, and we have very successful treatments, which are biologics or biosimilars, that work this way. The blockade of cytokines is probably better known in many different disciplines of treatment. We can block many different cytokines, either, as I explained, by having antibodies to the cytokine, or we have also recombinant proteins that block the cytokine, or by blocking the receptors. And blocking these pathways has been successful in treatment of diseases. In addition, we can also blockade circulating factors in the case, for instance, of bevacizumab and denosumab, where they're not actually blocking a receptor on the cell, but they're blocking a soluble factor that will no longer be able to engage with its receptor. And it has the same effect as blocking these cytokines or these growth factors. Now, in this particular area of extracellular work, we could also have certain examples where we're not blocking, we're actually stimulating by mimicking the engagement on the receptor, and we produce agonism of that particular receptor, which is the case of filgrastim and also epoetin. So these particular therapeutic modalities will now use the system and extracellularly bind and activate the receptor. So these are just a few examples, but when you do have a potential for using a biologic or a biosimilar drug for your patients, or if you're a patient and you are given one of these drugs, you can look at the mechanism of action and understand how this is working and how this is blocking or stimulating the pathway that you need to modulate for the control of the disease. Now, looking back at how this system works, remember that extracellularly is basically an engagement of the receptor, and that's what we can block. But it has to be specific to the receptor and the ligand. Intracellularly, we have a mechanism that's actually the one that translates that signal into a gene transcription. So an alternative to the biologics and biosimilars, we have small molecules that can target intracellular pathways. And by having a small molecule that penetrates the cell membrane and can block any one of these relays that are activated, there's no gene transcription because there was no phosphorylation. These are typically kinase inhibitors, and the advantage is that they have increased the potential for modulation of many different pathways. We're no longer now limited to inhibiting a particular cytokine, but we can inhibit pathways that could be shared by several different cytokines with only one drug. So both ways of controlling diseases are very efficacious, safe, and useful, and they're available. And the choice of one or the other has to be done by an educated understanding of what am I achieving with each one of these drugs, because they are not the same. In terms of the signaling of these cells, what I put in here is the many different cells, just to remind you that these receptors are found both in lymphocytes but also outside the immune system. Cells communicate and talk to each other by these receptors, and by having the receptors engaged either by other receptors on cells or by cytokines that are secreted by these other cells. And there's 6 superfamilies of receptors. These superfamilies are identified by what's inside the cell. So the type 1, type 2 cytokine receptor will signal through what we know as tyrosine kinases. So these are associated tyrosine kinases that signal via the stats. And these are usually known as the Janus kinase systems. It's the JAK-STAT system. The next group or superfamily is what we know as the toll-like receptors or the interleukin-1 receptor. This is the case that uses MyD88, which is a myeloid-derived cell line where this adapter protein was found, and it basically stimulates different kinds of kinases. So whereas the type 1,2 cytokine receptor uses JAK-STAT signaling, the toll-like receptor or interleukin-1 receptor uses the IRAK kinase and signals through the NF-kappa B. So it's a different way of translating the signal from outside to produce a different kind of gene transcription. The third superfamily is very well known to us, is the TNF family. It has 3 chains, and instead of the 2 chains that the other 2 families have. But interestingly, inside the cell, it will signal through what we call as the MAP-Cap kinase or the MAP kinase signaling system. Again, going to the nuclear factor kappa B. TGF-β is a receptor that uses serine or threonine kinase. Different from the tyrosine kinase that is used by others, serine or threonine kinase are important, and the TGF-β is typically a soluble factor that would automatically be associated with tolerance, immune tolerance, and anti-inflammatory effects, contrary to the others which are more pro-inflammatory. So it is a slightly different effect, and not surprisingly has a unique different way of signaling to the cell intracellularly. The chemokine receptor will use cyclic AMP via the phosphodiesterase E4, and this is different from others that use ATP. This is the one that uses cyclic AMP. So again, intracellularly, it's very distinct from the others, and this is why they're called the superfamilies, of which the 6th and last is the receptor tyrosine kinase. So you might actually be wondering what's the difference between this one and the first one I described. Well, the difference is that even though both of them will signal through tyrosine kinases, in the first case, the tyrosine kinases are separate proteins that are physically associated to the inside, to the intracellular domain of the receptor chains, but the receptor does not have the kinase. All the others have the kinase in the receptor, and this last one, receptor tyrosine kinase, has the specific tyrosine residues within the receptor chain, the little tail inside, and that's the way they signal intracellularly. Understanding these different superfamilies is important because we have actually armamentarium that uses all of them actually. So when we see, for instance, tocilizumab, ustekinumab will block a type 1,2 cytokine pathway because tocilizumab blocks the IL-6 pathway which signals through this JAK-STAT pathway. Ustekinumab blocks IL-12 and 23, which signals through the JAK-STAT pathway. And of course, tofacitinib and all other JAK inhibitors signal through this one. So the difference is we have here available extracellular inhibition with tocilizumab and ustekinumab, or intracellular inhibition via tofacitinib. So even though these 3 act on the same type of receptors, their effects are distinct and different depending on exactly what is their specificity, but we have experience in the clinic on modulating this particular superfamily of receptors. Likewise, hydroxychloroquine will work intracellularly on the toll-like receptor pathways, and anakinra will inhibit the interleukin-1 pathway. This particular receptor is a receptor that mediates the stimulation of the inflammasome. In other words, this is a receptor that's very active in gout, for instance, because it's one of the ways that we deal with crystals. And it's very active also in dealing with several different pathogens because it's a toll-like receptor and the inflammasome. So inhibiting this pathway is a way of controlling the auto-inflammatory diseases, contrary to the autoimmune diseases that you would be controlling with the first receptor. So we have examples of inhibiting these two kinds of receptors, both extra and intracellularly. This is slightly different for the TNF receptor story because this is a receptor that intracellularly is very complex. It has a lot of redundancy intracellularly, and it's much easier to block extracellularly. So we have other TNF inhibitors or blockers available, and also belimumab, because BLIS is a soluble factor that signals through this receptor superfamily of TNF receptors. So these different extracellular mechanisms for biologics and biosimilars will control those signals that use the TNF superfamily. And again, examples of intracellular inhibition in this case are not available, basically because it's very redundant intracellularly. It uses a lot of different kinases, and it's easier to block it in terms of extracellular blockade. The TGF-β is a very active field of research, especially in the immuno-oncology arena, both intra and extracellularly. The chemokine receptor is one receptor that is inhibited by both apremilast and fingolimod. Basically, these two are intracellular mechanisms that will use the fact that you can block the CAMP or the PDE4, and that way the other receptors are not inhibited. It's a very specific chemokine receptor inhibitor. Bevacizumab is a very good example of an extracellular inhibitor of this final superfamily of receptors. I hope this was useful to understanding at least a beginning of how do we use extra or intracellular blockade or modulation in the different drugs that are available. And of course, I'm adding here the references that also explain the different drugs that I mentioned as examples. There are many other examples, and just feel free to look on more recent publications, look for more examples, and of course, check my YouTube channel where I have several other educational videos. I hope this helped.